And as a our last CGR ended with a case of renal cell carcinoma who required palliative care. So CGR we had actually made an effort for one of our patients for whom Dr. Neeti from community medicine had also integrated with our radiation oncology OPD, Dr. Saurama SR, all and our nurses and OPD, all have taken care of one patient. In the spirit of palliative care, we wanted to share our experience and so that we can elaborate few of the key concepts which are not very different but needs to be understood in a different way, keeping in for a palliative care. Dr. Neeti, Dr. Saurama, my senior resident, he will come and introduce about how we saw the patient for the first time in our OPD.
Thank you, sir. Good morning, respected teachers and colleagues. The journey of Mrs. X with us started in October 2013, which continued in March 2014 till the end of her life. When she presented to OPD, she was a 55-year-old female who came from Muslim community. She was a resident of the old city of Jodhpur. She did not have any comorbidities. She had habit of chewing tobacco since last 20 years. She presented with us with complaints of ulcer on tongue since 6 months, swelling on both sides of neck since 5 to 6 months, associated with difficulty in swallowing food since 3 months, and pain in the mouth which radiated to ear and bilateral upper neck since 1 month. On general physical examination, her general condition was poor. Her RFC performance score was 60. She was a pale lady with dehydration and malnourishment. There was no pallor, icterus or edema. Systemic examination was grossly normal. On local examination, the mouth opening was adequate 3 to 4 cm, but orodental hygiene was very poor. On palpation, there was an ulcer-proliferative region palpated in oral tongue, which involved the left nasal border predominantly and extended across the midline. Floor of mouth was also involved. There was total ankylosing of tongue. Bilateral level 1 and level 2 hard fixed lymph nodes were palpated. The maximum size of lymph node was 3 cm. There was also a right-sided submental lymph node palpated, which had a small impending fungating area. The report she was carrying was biopsy, which was moderated differentiated squamous cell carcinoma. Rest of the basic investigations like hemogram, liver function test, and renal function test are normal.
The patient has already been seen at GCRI, Ahmedabad, at MDM hospital in Jodhpur. Biopsy had been done from the ENT department, and which showed that there was extensive growth in the oral tongue, also going towards base of tongue, towards the floor of mouth, and there were large multiple lymph nodes of level 2 and level 1. One of the node and the mass were conglomerated. Axel chest was clean, and if you read the MR report, significant features were there. Deep muscles of the tongue were all infiltrated. The left retromolar triangle was involved, body of mandible was involved, floor of mouth, myeloid sling, they were also infiltrated. So we had a diagnosis of clinically a T4, N2C, that is bilateral neck node involvement, and metastatically 0, no mets at present. So she was diagnosed with as a loco-regionally advanced tongue cancer or having loco-regionally advanced oral cancer. Going briefly from the guidelines, we get that such patients are inoperable in nature and they need palliative care. Part of that is a palliative radiation which can reduce the mass, reduce this pain, bleeding, halitosis, fungation, all can be addressed by that. And there will be a lot of symptoms which are to be treated in a preventive and therapeutic nature. Psychosocial and spiritual, which most of us still need to learn more, that care has to be integrated. So, as we will go, as the course of presentation will go, we have tried to integrate the different points from the definition of palliative care, how we try to match with them. Now, palliative care is a WHO definition, very nice definition, very comprehensive one. It improves the quality of life of patients and their families. We have to take into account their families, and then it starts for the patients who are facing the problem associated with life-threatening illness. So we have to first establish that the illness the patient is facing is a life-threatening. For this patient, yes, it is a locally advanced oral tongue, and we don't have a minimal cure for such a patient. Through prevention, we have to always keep in mind what next problems patient can face, relief of suffering, means of early identification, impeccable assessment. It doesn't mean the patient is not curable. We don't have to do impeccable assessments, we don't have to score, and we don't have to spend time for going through all these procedures. Treatment of pain. Pain is see separately from all the physical problems. Pain has been kept separate. Other problems, physical, psychosocial and spiritual. And this continuum of care may just demonstrates that the paradigm shift which had happened in last decade, that palliative care, the moment we identify, diagnose that patient is going to deal with a life-threatening illness, end of life will be caused by that particular disease, the palliative care has to be integrated. Maybe it will play a smaller role when the patient's general condition is very good. But as the time will go by, the role of palliative care will increase, and it continues even after the death of patient, because the family has been burdened by such a long duration of this chronic disease, and bereavement care is to be integrated in this palliative care. Now I invite Neeti to emphasize a few different points of communication in an effective way where palliative care is concerned.
Thank you, Dr. Pareek. Communication in palliative care is basically different from the essential principles of communication we take care of when we deal with patients. And it is different because we are dealing with a patient who is approaching end of life. So we have a small exercise designed, and I would like our GRSRs to respond to this so we can discuss basic essentials of communication. Patient has right to know all information about this disease. The house agrees or disagrees on this. Yes, the patient has right to know all about the information, what disease he is suffering from, what are the treatment modalities, prognosis of the disease, and what all our setup has to offer that patient. So we all agree. Doctors generally have a fair idea about what a patient knows. Agree, disagree? Disagree, yes. Generally, we consider that patients are not aware much about their disease. But that is not true. Patients are generally aware about their disease because of the various caretakers, multiple care providers they have been referring to, news, media, internet now. So they definitely have a fair idea about their disease. And when a patient is suffering from end of life disease or life-limiting illness, they have that kind of mindset, and these all principles are important to keep in mind while we are trying to prognosticate our patient and not trying to give any false hope that patient will be relieved in the course of illness. First reaction to bad news is sadness, anger, crying, shock, denial, or anything else. First reaction to bad news is, please GRs, SRs, please respond.
Shock.
First reaction to bad news is shock. Generally, as soon as we give bad news to the patient goes in a state of shock because they might not be expecting that kind of news, and they have turned to the setup in search of some curative component of care. So this is important to understand, because after you have given bad news to the patient, you should give a pause. Try that so that patient can absorb that news, and thereafter you should start building upon your prognosis or the treatment strategy. So first reaction is generally shock, and patient should be given some time to absorb that news. All facts given about illness are remembered. No. Yes, generally because the patient goes in a state of shock and there are so many overlapping factors. They are trying to make out of the disease, how the disease will affect their future course of action, what will happen to their pending responsibilities. So generally illness, facts related to illness and their prognosis and their management is not remembered. So doctor or treating physician has to emphasize the key points again and again in the course of communication. Verbalization and expression of feeling is harmful to the patients. Please respond. No. Yes, it is therapeutic. If patient burst into tears, or they turn silent, or they don't want to interact any further after you have given bad news to them, you should encourage patient to respond, to express their feelings, and in case patient don't want to talk, you should accept that and try to convey patient that they can come later and they can communicate anytime. So this is important to understand that verbalization and expression should not be discouraged. It is not possible to explore the concerns without giving information. House opinion on this? That it is not possible to explore the concerns without giving information. Yes or no? Yes. Actually, it is no, because generally patients, they are not worried about disease per se, they are worried about what will happen to their family, who will take care of their responsibilities. And treating physician has a very limited role to play in this. So what they want is a supporting help or a patient hearing response. And generally, physician cannot provide much of information on what will happen to their financial things, or how they will be able to take care of their family thereafter. Per se disease and the prognosis physician can answer, but there are multiple concerns which Dr. Pareek will be deliberating upon in terms of psychosocial and spiritual issues. So probably physician may not have answer to all these, but it is important that you give a patient hearing to all the concern what patient is trying to convey. Skills in breaking bad news makes the news not so bad. Please be loud. Yes. Actually, what the literature says is, no, bad news remain as bad news. What skills help is that it helps the patient to understand that they have a supporting or an encouraging platform or a background who can give them some sort of a supportive care. But bad news will remain as bad news, but the way you deliver bad news is important.
For this question, I partially disagree with Dr. Neeti. I told it's not so bad for the doctor.
Yeah, because
for doctors it
have
becomes
their own-
easier if the set of skills are read and repeated. But for the patient, it is always usually bad. Patient is the problem.
And this takes us to again the second point or third point, that whatever skills you employ, you have to give time to patient to absorb that component of news. Please don't tell really means please don't call. Please answer.
Sometimes patients say, please don't, I don't want to know much detail about that, please explain to my son or daughter, or like that they will say, and then they will say, okay,
Or I don't want to hear
he will
about
meet
any
you,
further.
he and she, they will meet you, or he is there, you please explain to him, I am not much concerned about all the procedure and everything. So what do you think? We think that patient doesn't want to know, or he is afraid of being hurt?
Yes, definitely. Please don't tell us that denial phase you were referring to. The first phase that comes after patient has overcome that shock, that no, such a thing cannot happen to me and therefore I don't want to hear much about this. So you should give time to patient and then refer, then ask patient to come back, or you can give option that whether patient would like to whether patient would like physician to convey this segment of news to some near dear one. When in doubt, what you do? Assume, make a guess, change topic, or do anything else. When in doubt about anything related to patient line of management, or how the patient will respond to your...
Patient has a new symptom, for example, dyspnea, and we have a doubt about what is the cause of dyspnea. We still do not know whether it is treatable or not. The patient...
Answer is when in doubt, don't make guesses, don't assume, please ask the patient, because we keep on telling that patients, they know much, they have a fair idea about their disease. So ask the patient or the patient relatives. So it is actually anything else. That when in doubt, physician should ask what patient is going to do. how you end your communication after you have relayed to the patient, you have given the bad news, patient has like gone through that phase, and then how you end your communication. Generally, we try to end by checking upon the patient that how he's feeling, whether he's ready to accept the line of management, what course of action we are planning to take. So this is the way we generally end the communication, that yes, cure is not possible, but we can palliate the pain and suffering, and we are there to care, we are there to offer care to the patient.
Maybe it's the first point itself when you say patient has the right to know. Are we talking about the patient directly or patient's family?
Everyone.
No, no. It's a very Western concept that patient has the right to know. I body, I decide what is to be done. But here when you treat cancer, you start the discussion with the patient directly. The first thing is that it just said that you are if you start and say no, he will be deciding, do it, and you have such angry or an upset family that आपने इनको भी बता दिया.
Yes, sir, this phenomena that sir is
So
referring to.
the whole thing communication now, the first point has to be very clear as to what do we mean by that. For the rest of the things get linked to it.
Agreed.
Sir,
As sir has said, in India, whenever we have experienced in India only, for example, family is the first who is going to actually take care of all the responses or phases which patient is going to face now. So when we break the news, actually we want to reach ultimately to the patient, but for that our first step is to be share with the family and make them agree that revealing such information as per their permission and graded information to the patient will be useful. Because family initially had a reluctant approach, please never tell, you do all treatments but never tell the patient what he or she is suffering from. However, we ask family always that if patient knows this, the compliance will improve, and do not worry, he will recover, he or she will recover out of it in some time.
as sir and Dr. Pareek refer to this phenomenon is known as collusion. Collusion is maintaining conspiracy of silence or misinformation. And generally in this patient also it happened that when Dr. Pareek introduced the patient caregivers to me that madam will take the history and all. So the first thing patient caregiver, her son, the son of the lady, he told the lady that ये डॉक्टर कह रही है आपसे सब कुछ पूछेंगी और फिर आपका इलाज होगा और सब कुछ ठीक हो जाएगा. That was the first thing patient son told the patient while introducing me. So this phenomena is called as collusion, and there is a cost to this. If you let this conspiracy of silence prevail, that patient is not aware of the disease, or patient is not aware of the prognosis that disease will take, or how the treatment options will help the patient, then slowly the trust will fade away. Patient is aware that his disease is progressing and he is deteriorating, the condition is deteriorating day by day. And because the doctor or the care providers are continuously telling you everything will happen, will be okay after some time and you don't need to worry. So this thing will kind of create mistrust. Patient will slowly get socially withdrawn, will stop relating, because he or she is aware that whenever I tell them, they give me a false hope and I am not being helped because of that. And later on maybe patient may stop all the treatment modalities because he or she may of this impression that doctor and the caregivers are not able to provide me adequate pain or management of other associated symptoms. So we generally, the literature says that we generally
literature is mostly from the Western literature. Yeah, agreed. It's different in our Indian scenario, and family actually is the first. Even if family is fully informed, that is an achievement in our Indian scenario. It is same like informed consent forms. Something like
cultural difference should be taken into account. So Indian families should be taken differently.
First statement should not make any resident harsh enough that no, the book says I have to reveal. Catch up a patient, reveal it and just go away, vanish.
Dr. Pareek, is it not legally important to communicate to the patient himself? Sometimes down the few years later, he may say, I have not been treated, I have all rights regarding my life. I have right to know what my life is. I should be deciding what my life is.
So this kind of trust has to be slowly built with patient related.
It is legally important to communicate directly with the patient.
So, but taking into accordance with the patient relatives whether we should convey, because later on patient relative have to support the patient. So it has to be a mutual dialogue.
Agreed, sir. But many of our oncologists, as they are doing the training, first thing we stop doing is stop giving false information.
That is not right.
That is the right. Maybe the family is asking repeatedly in front of the patient that patient, ठीक हो जाएंगे. We never nod our head. We never say yes. We'll say, we'll talk, we'll see, we are evaluating like that. Then slowly we wish to.
And many times in oncology, medicals say that
Yeah.
Balance about how to deal with the religious information is that we talk to the attendant and the family first, and that can be done in the outpatient situation or whenever. And while if the patient is admitted and while on grounds, the family, the patient, the doctor, and probably a social servant should be present when we are disclosing the patient should come.
That's a challenge. I think it's a separate. Someday, these are very sensitive points. We can have a very.
Dr. Pareek, what I believe is not a blanket statement.
Yeah, it need not be a blanket
statement. It refers to patient to patient.
Actually, depends on the background of the patient. I feel it depends on the background of the patient. There are a lot of uses that are background. It depends on the background of the patient.
Again, the patient to patient it will differ. We may sometimes have an Indian oil executive who is coming alone with his friend, immediately understands everything. One more problem we encounter in rural patients is if we reveal immediately the bad news to them, they do not come back to us. They start exploring the doctors who are not telling it's a bad news, and they may be down like chemo also, and they may end up with doctors who say promise for a cure.
Educating the patient depends on whether you would like to promise urban background presentation, especially presentation in the cancer.
you wanted it interactive.
So we have a clear understanding that there is a problem while dealing with end-of-life patients, and it slowly comes with experience and how to deal with patient, because in India the typical setting is family comes first. So bad news is any information which adversely and seriously affect an individual view of his or her future. So as we discussed that there is a protocol which gives a clear idea that how you can deal with the bad news. It is to be followed by physician, that how they can break bad news to the patient or to the patient caregivers. Setting is important, that privacy need to be maintained. It should be a relaxed setting. Patient or care providers, they should be able to come up with their concerns. There should be eye contact, and interruptions on the part of physician should be minimized as much as possible. Then, as we have discussed, that patient have or care providers even have a clear perception of what disease the patient is suffering from. So we should try to assess that what they know about the disease, what is their level of knowledge, and what they have been through, what kind of concerns they have in their mind while taking care of the perception. Then, as we discussed, that patient may be in a denial phase. So physician should offer whether patient would like to know about this disease or the prognosis or the treatment management plan. Then conveying the knowledge to the patient. In the whole course of this communication, open-ended questions are to be asked. It should be exploratory in nature, and you should give adequate time to patient to respond through silence or by in whatever manner they want to verbalize or express their feelings. Then need to address their emotions. They may start crying, they may go into some depressive phase, and you can always acknowledge, tell them they can later come and relate to, and then strategizing your further treatment and management plan. This is important while patient is leaving your setting, that what further we can do for the patient, because palliative approach always says that care is not denied, only the cure option of the disease is denied, but we are there to take care of the pain and other associated symptoms which patient may suffer in the course of disease.
Spikes protocol is a good checklist, although our individual methods may be better than Spikes, but it's a good checklist in a busy hospital schedule whether we have missed something. For example, we should not hand over biopsy reports or bad news while in the corridor if we meet a patient like that, something like that. And then last point is a very interesting strategy. Like every time we end the conversation, we don't leave it blank. Just assuming that we had already prescribed some painkillers and antiemetics to patient, we always emphasize now this is what we are going to do. So there is a to-do list for a patient at the end. Patient is not sent helpless, like there is nothing to do anymore. We always create a to-do list. This is the pain relief, this is about diet, 2-hourly diet, you can take semi-solids, you have to use the mixi, then you have to bath daily, like that. Some points are created so that patient becomes involved and family becomes involved, that there are things still to be done till the end of it.
So ethics.
Ethics in palliative care, for example, beneficence. This is just to recapitulate, most of the things are taken from Indian Association of Palliative Care guidelines, and even the brainstorming questions are very much commonly used by Dr. Sushma Bhatnagar, team in AIIMS Delhi. Just to recapitulate the communication skills in palliative care, beneficence, whatever done for patient which is good for the patient. For example, for this patient, we knew that patient is having pain, so patient required morphine, patient required palliative radiation, patient required nutritional care. This has to be done. We always had in mind that even in future, if this patient develops lung mets or dyspnea or aspiration pneumonitis, we are not going to stop morphine. Although pharmacologically, medical graduate can think that morphine reduces respiratory rate. So we had in mind, we are going to continue with for pain relief. Autonomy. For this particular patient, Mrs. X, our decision that she should take palliative radiation was not enforced that go and take. We took time to explain, this is how rays, they are not hot or cold, you can't feel it and it will benefit you. She took, I think, 2-3 weeks to be convinced that she will go ahead for radiation, but nobody forced her. Then once during the course of her treatment, her swallowing stopped because of proliferative growth at the base of the oral cavity. So we advise that a nasogastric tube can help the drugs reach the body, and it's a simple procedure. But she didn't agree, as most of the patients initially. We took time, and by 2-3 hours I think she had agreed for an nasogastric intubation, and that's how we did it. So we tried to respect patient autonomy, non-maleficence. We did not want to do anything which would harm the patient. For example, there are many interventions like chemotherapies and cytotoxic chemotherapies that do regress the disease partially, however giving a lot of side effects. We never added for this patient because we suspected that this will deteriorate her performance score further. Justification of resources. We never admitted this patient for a long period of time. We never gave parenteral nutrition. We thought about a nasogastric tube. We didn't thought about giving intralipids and Carbi Pro and all the fancy parenteral nutrition which are not indicated for such palliative situations. So this is how we try to imbibe these ethics into our practice, but still we need to learn more. Now for spirituality in palliative care, still we have to integrate with Dr. Naresh's team for further patients, and we do not claim that this is our weakest. When Neeti, myself and Saurabh talk this, we think this is our weakest still portion where we do not understand so much. However, we have started understanding that it's different from religion. That it's why me, why I have suffered, and most of the patients are asking why I have suffered. I have never done anything wrong, although she was chewing tobacco, but intentionally nobody think wrong enough to suffer from any disease. Now, why me? What I have done to deserve this? Am I being punished? The philosophy of karma in India is very strong. Like it's because of our karma. Then what will happen to me at the time of death? Will I suffer? What happens after death? Is there God? Will I be forgiven for my sins? What will happen to my loved ones? Will I be remembered? So, she was a religious lady, and when we explained her that Amma, we will not be able to cure your disease, we are going to reduce your pain, we are going to address how you can take diet. If you take diet, you can take walk at your home, you can also walk outside, you will have strength enough. Then she did acknowledge Allah ki jo marzi. So this way she had a spiritual integration going on. We didn't understand how she did that, but at least these questions were answered by herself in 1 or 2 visits. She was having a communication with herself.
Pain is one of the symptoms which we try to give a lot of attention in palliative care. Pain is not just physical component. it says that pain has more than one component associated, that is psychological, social and spiritual. Physical symptoms we can understand because there are two types of pain, nociceptive and neuropathic, and as the disease is progressing it involves more and more organs. So it is physical pain is